I'd like to welcome you to our webinar. For purposes of clarification, I want you to know that this event has not been sponsored by the NIH, though we are honored to have them here today as presenters. So the focus on Lyme disease and pregnancy is of particular interest to me because it was not so long ago that I was an expectant mother, lying on an examination table at my final sonogram, wondering what on earth was taking so long. The doctor seemed to have been studying the images forever, squinting her eyes and furrowing her brow. Now, I'd already had a normal amnio and an unremarkable pregnancy, so I remember I was thinking something might be wrong with the machinery until suddenly the doctor looked at me and said, "I'm sorry, but there's been a failure to thrive." Failure to thrive was a new term. Sorry, but, on the other hand, I'd heard before. Sorry, but I can't find any real reason for your joint pain. Sorry, but I can't find anything actually wrong with your brain function or your memory. Sorry, but there's nothing showing up in your blood work. Sorry, but I don't really know what's wrong with your eyes, your ears, your balance, your nerves, your bladder. I mean, let's just say I'd had plenty of experience with sorry, but. What was terrifying about that particular sorry, but, the one I heard at my 36-week sonogram, was that my lifetime of sorry buts were now clearly trickling down a generation. I already had a 6-year-old at home with multi-sensory integration disorder, asthma, anxiety, and social challenges. When I reflected further, I realized that my own mother had been plagued with a host of physical problems most of her life too. I began to wonder, were we just a cursed bunch? Of course we weren't cursed. We simply hadn't been diagnosed accurately yet with Lyme disease and its companion co-infections. That didn't happen for me until 2016. My first child was born in 2001, the second in 2009. My earliest known tick attachment was in 1976. It was followed by a textbook list of Lyme symptoms that were left unrecognized and untreated, which means that I carried 2 children to term while I was clearly infected with Lyme, and by Lyme I'm including Bartonella and Babesia. By the way, I think it's really important that you know my doctors were not negligent. They were at the top of their fields in New York City, working at centers of excellence. I had been tested multiple times prior to pregnancy and during both pregnancy, but on all occasions, my Lyme tests came back negative. Today, we know that those blood tests are often inaccurate, but my doctors went by the science, and the science said I was fine. But I wasn't. And now my husband and I, just like millions of others the world over, are living with the impact of misdiagnosed and untreated Lyme disease on our family. We will never raise a child who wasn't born with microcephaly, who isn't on the autism spectrum, who hasn't spent more hours in intervention programs than at play with any peer, who might not ever live independently. We will never raise another child who didn't have an IV in her arm by the time she was 4, whose Lyme-induced PANS became POTS, PCOS, OCD, and ADHD. The very first account of congenital Lyme disease was published in 1985 by Yale scientist Dr. Alan Steer. That was 36 years ago, long before either of my pregnancies. Can you imagine? If that 1985 data had been shared widely, if it had been taught in every medical school, it had been followed up by 36 more years of research, what a different life my 2 children and I, and perhaps millions of others, might be living. Think of how the course of history might be different. The last 36 years have seen a rise in the case of autism spectrum disorder diagnoses, learning disorders, pediatric arthritis and pediatric MS, gender dysphoria in children and teens, self-violence like cutting. The last 10 years in particular have seen a rise in the number of women who died during pregnancy and childbirth, a rise. Could these conditions be attributed in any part to undiagnosed or unrecognized infection, including tick-borne disease? In a COVID-ravaged world, we can no longer underestimate the profound impact an infection can have on our lives. We must ask, are there dots we are failing to connect between ourselves as mothers and the generations we are birthing? All around me, I observe similar multi-generational scenarios of disease attributed to autoimmune syndromes, cause unknown. A grandparent with Parkinson's or Alzheimer's, a bipolar mother with chronic fatigue, rheumatoid arthritis, Crohn's, psoriasis, a father with ALS or MS, children often labeled as attention seekers or lazy, who spend whole years in bed missing key developmental experiences they will never regain. Families devastated financially by out-of-pocket medical expenses, sick parents struggling to keep their careers afloat who stay up all night researching special ed programs and special doctors with waiting lists that are months to years long. Entire identities are being forged in the flames of sickness and confusion. We must figure out what is causing what so we can end the cycle. The HHS Tick-Borne Disease Working Group has recognized pregnant women and children as special populations who suffer disproportionately from tick-borne diseases. This working group has also noted that gestational Lyme disease can cause premature labor and fetal death. The CDC recently updated its literature and website to recognize maternal fetal transmission of Lyme disease, but it's barely enough. The message is not being heard and heeded universally because there's simply not enough data. A December 2019 letter from 7 US senators to Dr. Anthony Fauci asked, what research is the agency planning to conduct on Lyme disease to improve understanding of modes of transmission, including vertical transmission? Dr. Fauci replied that further exploration into non-vectored transmission of Lyme disease, such as vertical transmission, was indeed needed to conclusively identify these routes as contributing to Lyme disease burden. Dr. Fauci himself has opened the door. Now we need you to walk through it. Not only do we need an accurate diagnostic for all people being tested for Lyme, we need a sensitive and specific diagnostic which can readily identify Lyme infection in pregnant women, especially those who may be asymptomatic. We need longitudinal studies. We need to determine the appropriate antibiotic regimen to prevent transmission of Lyme disease from mother to fetus. We need to examine the effects of pregnancy on immune response and symptoms. We need to evaluate the role co-infections play. The list goes on, which is to say, there is much work to be done. It is time to get busy. Okay, now that you know why I came today, let's get down to the science. To start us off, I'd like to introduce Professor Holly Ahern, Associate Professor of Microbiology at SUNY Adirondack. In addition to being my Mothers Against Lyme board colleague, she's also co-founder and Vice President of Lyme Action Network. Without further ado, Professor Ahern.
Thank you, Isabel. I have to ask, am I sharing my screen yet? Can anybody see my screen? Okay, now. Hopefully we're good to go. Okay, very good. So Isabel, thank you for that introduction. And like you, I'm here as a mom. I did not have the same issues with gestational Lyme. My daughter was infected when she was just a child, but the issues are common to so many moms and so many people in general that I'm happy to be here talking about this subject today. So my job is to talk about the epidemiology and pathobiology of the disease. And I wanted to start by just discussing that Lyme disease, and actually Lyme borreliosis, is not an issue that affects only people in the United States. It's a global concern. And so this map that shows each little pin that you can see on this map indicates a country where research on Borrelia has been published, either Borrelia or Lyme disease has been published. And that, if you notice where all those pins are and the listing of the countries, there are 79 countries around the world that have issues with Borrelia, borreliosis, Lyme disease. So this isn't an issue that is confined just to the United States. It's not a small issue. It's actually a very large and global one. Now, moving to the United States, shown here is a distribution of cases of vector-borne diseases in the US in 2018. This is data that is from the surveillance numbers that are kept by the CDC. And this is just a distribution of vector-borne diseases in the US. So vector-borne diseases are diseases that are transmitted by arthropods. So in addition to ticks, mosquitoes are vectors, fleas are vectors, and it turns out that of these 12 diseases, they are all transmitted by one of those things. Also note that the ticks happen to be among the top vectors. So 6 out of the 12 diseases are transmitted by ticks. Mosquitoes, 5 out of 12, and then fleas, 1 out of 12, which is the plague at the bottom. But one thing I want to point out with this data is that if you look at the total number of cases of all other vector-borne diseases and even combine them, there's a total of 66,542 cases. So compare that to the 23,558 cases of Lyme disease that occur. And notice that for the same vector, well, actually, many vectors, but in general, the number of Lyme disease cases vastly exceeds that of all other vector-borne diseases by a factor of 4 to 1, in fact. And if you look at just the tick-borne illness, the next most common diseases are Ehrlichia and anaplasmosis, which, by the way, are 2 separate diseases. The number of cases, 4,000, it's over 5 to 1 for that. So Lyme disease as a vector-borne disease has a much higher number of cases than any other vector-borne disease. And I also want to point out that these numbers that you see here are very different from what you might have heard recently in terms of the numbers of new cases. These are cases based on passive surveillance that are collected as a result of case definition data. So in other words, reporting systems of cases that fit a particular case definition. So the case definition includes a couple of different things. The case definition includes a combination of a patient showing up with a particular type of rash called an erythema migrans, which is in the shape of a bullseye. And then also the other part of that is, in the absence of a rash, serological tests are performed, and a case could be determined by either the rash or serology, or a combination of both. But in any case, all of them require observation of a tick. So the tick bite itself is included in that case definition. So surveillance that is done by public health is just basically to capture an idea of how many cases there are, not necessarily reflect how many overall cases there are. But I am showing you this paper because looking at 2 things here: the appearance of a bullseye rash and positive serology is needed to diagnose a case or for case surveillance. And if you, when reading through the, some of the summary statements from this paper, notice that, the lack of provider awareness of the inability of providers to diagnose a particular rash as a type of Lyme disease rash can lead to underdiagnosis and delayed treatment. And also pointed out were, because this was a review of a biobank that has Lyme disease samples in it, that the current testing methodology, which is two-tier serology, is insufficient when it comes to trying to determine the number of actual cases that exist, because there was, especially early in the disease when antibodies are not detectable because they haven't reached the detection limit of the test. In very early disease, when antibiotic treatment is most likely to work, only 29% of individuals were positive for serological tests. So the point being, besides reinforcing the known limitations of serology, the paper also reinforces how difficult it is to diagnose someone with Lyme disease if the EM rash does not occur or if it's just not seen. And this is particularly important because of the fact that early diagnosis is needed in order to ensure treatments are effective. So this is a paper that was published regarding, it was actually on pregnancy and the outcome of erythema migrans rash in pregnant women. And I'm going to be talking about this paper again in a while, but notice that two major conclusions of the paper were that pregnant women less often had a ring-like erythema migrans rash, so they were less likely to develop the rash, the diagnostic rash, and they're less often likely to report constitutional symptoms, meaning flu or other, feelings that you actually had the illness. So because of that, the other research showing that serology really doesn't detect infection in newly infected pregnant women. Based on the way that Lyme disease is currently diagnosed, pregnant moms are significantly less likely to get diagnosed early enough in the infection to prevent dissemination of the disease and long-term chronic symptoms. They don't get the rash. Serological tests are not very effective in the beginning stages of the disease. So this puts pregnant women at a higher risk. So how many people actually do get Lyme disease? Earlier this year, in acknowledgement of the limitations of their passive surveillance system, the CDC published research which estimated the actual number of cases of Lyme disease to be closer to 500,000 new cases every year. So that's a big increase over 23,000 cases. So they're estimating, based on insurance claims, that there are close to 500,000 cases of Lyme disease that are diagnosed and treated for Lyme disease each year. So I looked at this data from a slightly different perspective. Instead of placing it among vector-borne diseases, I looked at it in the context of sexually transmitted diseases. And when you look at that and compare the estimated cases of Lyme to the top 3 sexually transmitted diseases in the US, which, by the way, are chlamydia, gonorrhea, and syphilis, by the way, Lyme disease overall is the 3rd most common bacterial infectious disease in the country presently. There are slightly fewer cases of Lyme disease than there are of gonorrhea. And I want to point out that gonorrhea is a bacteria that is easy to culture, that can be cultured. There are tests available to detect, same with chlamydia. And there are screening programs for pregnant women to detect these types of sexually transmitted diseases. And then I also want to point out that there are 4 times as many cases of Lyme disease as there are cases of syphilis, which happens to be a spirochete, an illness caused by a bacteria that has similarities to that of Lyme disease. So, just kind of looking at that within the context of, the vector-borne disease data, ticks just do not appear to be great vectors for diseases because most other tick-borne diseases do not get to be such high numbers. And looking at the distribution of the vectors in the US, again, this map was published a couple of years back. Those are the disease vectors. Those are the vectors that transmit Lyme disease to human. And notice that half the country lacks the appropriate vector for this disease. So we have the 3rd most common bacterial infection being transmitted by vectors that aren't in half of the country. So all of that data strongly suggests that there are other routes of transmission for this disease. And I'm going to say that this and data from other researchers also strongly suggest that humans have become reservoir hosts for Borrelia, just as humans became reservoir hosts for diseases like syphilis and tuberculosis over centuries. Yet to this moment, tick-borne is still considered the only mode of transmission for Borrelia burgdorferi, and there's a great deal of time and energy devoted to prevention of tick bites and awareness of tick bites and the impact of that. So what could some of the other possible routes of transmission be? Just pointing out that spread from a pregnant woman to her fetus has been suggested as a route of transmission for Borrelia since the 1980s, as Isabel pointed out. And so looking back at the historical research, starting with animal models, which is where this type of research often begins, what you see here is a list of citations for publications that were published between 87 and 1999, I should say 1987 and 1999, for studies using animals in which transmission from a pregnant mom to the offspring were found. So the animal models in this list include mice, rats, hamsters, guinea pigs, rodents, which are known to be reservoir hosts for Borrelia. But notice also that there are included in this list are dogs, coyotes, cows, and horses, which are not reservoir hosts. These are mammals like us who happen to be the unlucky recipients of the bacteria from tick bites. So the research is, right here is comprehensively states what we, it forms a background for where we can go from here. And this is just showing some of the quotes that I pulled out from those articles, and just reading through them, you can see that, many of them point out, gosh, there is the possibility that non-arthropod transmission could introduce the spirochete into populations, that is transmitted by other modes than tick bite, that it could be in a population in the absence of tick bites. And the quote in the middle, I think is, I highlighted it in orange because I just really think that it's very poignant. The assertion that serology, meaning the detection of antibodies against Borrelia, is not an effective means to detect whether babies born to pregnant moms with Lyme disease acquired Borrelia in utero is profound. And I bring this up because most of the research on human cases done so far, where it's been more or less determined that this shouldn't be an issue, has been done with an overemphasis on antibody detection to identify if babies born to moms actually have Lyme disease or not. So you can't identify adults that have Lyme disease using current serological tests, and you certainly can't identify whether babies born to moms are actually infected with Borrelia or not. And that will be discussed later on in the webinar as well. So moving on to the public health side, the messaging on vertical transmission as an alternative route of transmission of Borrelia has pivoted twice. In 1985, studies were underway to investigate Lyme disease in pregnant women. So the first pivot occurred roughly 2 decades ago. And archive CDC guidance actually shows that that the messaging on Lyme, was there in the 1990s, 1980s, 1990s until about 1996. And that corresponds to when the last animal studies were published in 1999. And by 2001, all mention of maternal fetal transmission was dropped by the CDC. And I also want to point out that in 2020, the language you see here reappeared, which most view as a step in the right direction. And it certainly is. It bridges the gap between the Lyme community and the CDC on this issue, and it acknowledges that there are other possible routes. However, there's language in there that I just have to point out that is not really supported by published data. The first being that the spread from mother to fetus is possible but rare. And there really is no data to tell us whether it is rare or whether it is common. And that's why such studies are needed to determine the frequency of this type of transmission. And then the second assertion, which is that there's no increased risk of adverse birth outcomes when pregnant women with Lyme disease are appropriately treated, that is not at all supported by the available data that we have. So starting in 1985, vertical transmission of Borrelia was acknowledged and a registry was established to study this issue. None of the data was ever published, but note that in 1985, the MMWR reported on this issue. MMWR is the Morbidity and Mortality Weekly Report, fascinating reading. And that was because there was a case report on a child that was born with a heart defect, which was attributed to the mom's Lyme disease. So in this particular study, heart defects were not identified in the small group, but other adverse outcomes were noted. The adverse outcomes were fetal death, premature birth, and cortical blindness, which is due to damage to visual pathways in the cortex of the brain, meaning it's a neurological condition. It is not, due to it's basically damage to the nervous system. So note that the conclusion at the end, the MMWR reports that it was emphasized there that 14 out of the 19 pregnancies were completely normal, which means that 5 out of the 19 pregnancies were not completely normal. And that may seem like a small number, but that's 26% of the pregnancies that ended up with fetal demise, preterm birth, or neurological issues. So moving on to that second assertion that there's no increased risk of adverse birth outcomes with appropriate antibiotic treatment, reminder that the adverse birth outcomes noted in the intrauterine fetal demise in the second trimester, prematurity and development of cortical delay. Okay, so just a reminder before we move on to the next slide. So these are 3 studies published between 2010 and 2020, which indicate that adverse birth outcomes for pregnant moms with Lyme disease occur at a rate of between 11 and 32% in moms who receive appropriate antibiotic treatment. The rate is lowest, 11 to 14%, in moms who are diagnosed and treated with IV antibiotics. But looking at it another way, 1 out of every 10 pregnant moms who was diagnosed and treated with an IV antibiotic still experienced preterm birth or death of their fetus, or the infant was born with a neurological defect. And just for comparison, an estimated 1 in 8 women, which is 13%, will develop breast cancer, and for which there are comprehensive screening programs, early treatment options widely available. Breast cancer is not considered rare. So I guess it all comes down to how you decide to define rare. But notice on the undiagnosed side, upwards of 50% of the pregnant moms who were undiagnosed and untreated for Lyme disease experience fetal loss, stillbirth, or offspring malformations. So I don't think that 1 out of every 2 pregnancies is rare. I think it is far more common than most people think. And remember that currently providers have a very hard time diagnosing Lyme disease in everybody and all people, but particularly pregnant moms because they don't have the same presentation. So this is the last of the 3 papers that I showed you this paper previously, summing up what else is known. So women in general have different immune responses to Borrelia. Pregnant women don't get rashes or constitutional symptoms. No rash or symptoms in pregnant moms mean that pregnant moms are less likely to get diagnosed. And then I also really feel that I needed to point out something here also. So notice in the stated conclusion, the course of early LB during pregnancy, the outcome of the pregnancy with the treatment approach is favorable. So that's the conclusion. But notice that looking at the data, that 14% of IV treated moms had adverse outcomes of the pregnancy. So that's 14%. Preterm birth occurred in half of those moms. Fetal death occurred in a quarter of them. So I'm not exactly sure also here what favorable refers to. So the treatment was favorable unless, of course, you happen to be among the 14% of women where it was not favorable. So from the beginning of research on Borrelia as a cause of human disease, the similarities between syphilis and Lyme disease or Lyme borreliosis have been noted. Those similarities include they're both very complex diseases. The bacterial causes are both spirochetes, which are profoundly gifted bacteria when it comes to pathogenicity. Both bacteria disseminate and establish permanent infections in mammalian hosts. Both diseases are very difficult to treat once those permanent infections are established. Diseases have differing early symptoms, but symptoms are very similar in later stages, and both show similar rates of antibiotic treatment failure. The difference here is that syphilis is a public health priority, and there are screening programs to detect syphilis in women before they get pregnant or while they are pregnant. And even with these screening and public health programs, syphilis is still a risk to babies because, as you see here, there are gaps in testing and treatment, detection occurs too late in pregnancy, and congenital syphilis is actually a medically recognized condition, whereas congenital Lyme disease is not. So although this discussion has been largely about Lyme disease or Lyme borreliosis, I really need to point out that other species of Borrelia are distributed all around the world, and relapsing fever Borrelia are known to cause symptoms that are similar, and relapsing fever Borrelia such as Borrelia miyamotoi, which is transmitted by the same ticks that transmit Lyme disease, are well known to be transmitted transplacentally. And just to finish out, the working group, the tick-borne disease working group in 2018 paid attention to this and noted that these are areas that we have research gaps in. The NIAID strategic plan that was developed as a result of the tick-borne disease working group points out that we need to improve the fundamental knowledge on detection, prevention, and treatment of tick-borne diseases, and pregnant women fall into all of these categories. So first and foremost, we need a test that can accurately identify people who are infected with Borrelia early enough so that antibiotic treatment can make a difference or recognize other treatments that might be effective. And this was repeated in the Tick-borne disease working group report of 2020, which included the recommendation that further evaluation of non-tick bite transmission of Lyme disease should be looked at. And I'm going to end with this quote from one of those papers that I showed you. It was published in 1993 on the in utero and seminal transmission of Borrelia burgdorferi in canids, dogs. And I just thought that this statement was as true then as it is now. It is surprising that the evidence presented for transplacental transmission has received little notice by investigators. It would seem that the clinical and epidemiological implications of significant could have an impact on current thinking and measures taken to manage the disease. So thanks very much. And I'm looking forward to hearing the next speaker.
Thank you, Professor Ahern. Now I'd like to introduce you to Sue Faber, RN, founder and president of Lyme Hope, whose expertise lies in an analysis of the literature that exists on maternal fetal transmission of Lyme and congenital Lyme borreliosis. Sue, take it away.
I just need Holly to unshare her screen so that I can share mine. Okay, just give me 1 second here. All right. Can you see that? Can you see this? Oops. Oh, where did we go? Whoop. Sorry, I tried to share my screen. Did you see it? No? Okay, let me try again. Excuse me. Oh, okay. Let's try this again. Okay, can you see my first slide? All right, let's get started. Thank you. Thank you, Isabel. This evening, I will distill and highlight what has been published on maternal fetal transmission of Lyme into the most salient points. I've compiled a supplementary information package with more detailed information and citations of what I am reviewing today, which is available under the Research tab of the Lyme Hope website. I trust that by reviewing what is known, which is little, what is understudied and unstudied, which is much, and identifying research gaps and opportunities, Then in turn, we can work together as part of what I envision to be a multidisciplinary relay team that collectively moves this field forward. I will be providing a brief overview of maternal fetal transmission of Lyme and adverse outcomes, following by identifying 2 research areas which require further investigation, followed by a case study. I will conclude with an overview of research opportunities. So let's begin. The current or 8th edition of Remington and Klein's Infectious Diseases of the Fetus and Newborn Infant is an authoritative medical reference textbook. Authors in the first chapter recommend expanding the well-known acronym TORCH, which readily identifies microorganisms responsible for infection of the fetus, to TORCH's clap, with L representing Lyme, as you can see I've highlighted in yellow. In a separate table, they highlight that Borrelia burgdorferi can result in congenital disease, or a baby born with the infection. The question is, what is congenital Lyme? Has it been characterized or defined? Is there a case definition? The answer is no, and not yet. So what data supports maternal fetal transmission of Lyme? It dates back to 1985, when the CDC issued an epidemiological bulletin in their MMWR, alerting colleagues in public health that transplacental transmission of Borrelia burgdorferi had been documented in a pregnant woman who was infected with Lyme in her first trimester, as evidenced by an erythema migrans rash. She did not receive antimicrobial therapy, and her baby died shortly after birth. Spirochetes were identified in multiple organs, and widespread cardiovascular abnormalities were noted. Later, Borrelia burgdorferi was identified in the myocardium by pathologist Dr. Alan MacDonald. The CDC acted quickly to communicate the findings of this alternate mode of transmission and alert colleagues to the potential for adverse outcomes. Later, the WHO and Canadian Federal Health followed suit and issued similar bulletins. An article co-authored by Drs. DeRay and Steer, who were both involved in authorship of separate publications on maternal fetal transmission of Lyme, stated this, and I quote, "It is clear that Borrelia burgdorferi can be transmitted in the blood of an infected pregnant woman across the placenta into the fetus. This has now been documented with resultant congenital infections and fetal demise," end quote. In 1985, the CDC initiated a Lyme and pregnancy registry. A short bulletin published in the Journal of Clinical Pediatrics also mentioned that cases of Lyme disease in pregnancy should be reported to both state health departments and the CDC. I see a real opportunity for this registry to be reinitiated to inform epidemiological surveillance and collect important data. Perhaps this could be accompanied with the formation of a biobank or biorepository with samples from mother-baby pairs such as placentas, amniotic fluid, cord blood, serum, urine, breast milk, and other tissue, which could be accessed by researchers for further investigation. This kind of information could inform the creation of a surveillance and case definition for congenital Lyme. The NIH has also published several iterations of a public-facing document on Lyme disease titled Lyme Disease, the Facts, the Challenge. Both a 2003 and 2005 version state, and I quote, "Infection can be transferred to your unborn child. Although rare, such a prenatal infection may make you more likely to miscarry or deliver a stillborn baby," end quote. In a 2007 paper published in the American Journal of Obstetrics and Gynecology, Lyme is included as one of the organisms implicated as etiologic for stillbirth, and a 2010 paper on infection-related stillbirths published in The Lancet also reports that stillbirth has been associated with Lyme disease. The UK Royal Society of Obstetricians and Gynecologists have included Lyme disease in their list of transplacental infections associated with late intrauterine fetal death and stillbirth. So given the risk of stillbirth and potential for other adverse outcomes, screening questions need to be developed and included in prenatal intake questionnaires at OB/GYN and primary care practitioner offices to identify women at risk for Lyme infection. So what is the data which supports vertical transmission of Borrelia burgdorferi? I don't have time to review each and every case, but I've outlined this information with full citations in the supplementary information package on our Lyme Hope website under the research tab, as mentioned earlier. This slide summarizes findings from a total of 22 publications, including conference abstracts, book chapters, and published papers. This includes 19 cases of findings through autopsy, from neonatal death, stillbirth, and miscarriage, 14 cases of live birth, neonatal infection, and adverse outcomes, and 17 cases of Borrelia burgdorferi identified by PCR in placentas of both treated and untreated pregnancies. It is clear there is limited data, but certainly enough to accept that yes, this organism can pass from an infected mother to her baby. But what does this mean? How does this impact babies who are born with the infection? Borrelia burgdorferi DNA has been identified by PCR in human breast milk in 2 cases of women with erythema migrans rash. There's also a case of PCR positive cow milk, an additional case of Borrelia burgdorferi cultured from cow colostrum. Isolation or identification of the infectious agent from breast milk is not proof of transmission, and there have been no reports of transmission through breastfeeding. A 2011 article on transmission of infectious diseases through breast milk and breastfeeding does have a section on Lyme disease and states this: the lack of adequate information on transmission of Borrelia burgdorferi via breast milk cannot be taken as proof that it is not occurring. Clearly, more research is needed to better understand if Borrelia burgdorferi can be transmitted through breast milk. In 1989, Dr. Weber, a leading researcher who was also co-author of a European case of congenital transmission, authored a paper on clinical features of Lyme. Table 1 in this paper identifies the main clinical spectrum of Lyme borreliosis, and as you can see highlighted within the red box at the bottom of the screen, this includes congenital disease. Recognizing congenital infection is a critical first step, but what is lacking is a case definition and how to diagnose, treat, and manage exposed infants. The 4th and 5th edition of Remington and Klein, Infectious Diseases of the Fetus and Newborn Infant, chapter on Lyme disease provides valuable insight and probably the most detailed overview and comprehensive data analysis on the subject matter of gestational Lyme and congenital Lyme up until 2001, when the 5th edition was published. The author, an infectious disease pediatrician, identified 66 cases with adverse events associated with gestational Lyme borreliosis, and this table highlights the frequency of fetal or neonatal adverse outcomes after gestational Lyme. This includes miscarriage, stillbirth, perinatal death, congenital anomalies, systemic illness, early onset fulminant sepsis, and later onset chronic progressive symptoms. In her chapter, Dr. Gardner compiled the 66 cases of adverse outcomes mentioned in the last slide, and she mentions that these categories were created, and I quote, into logical groups based on the understanding of the pathophysiology and clinical course of Lyme borreliosis in older patients, and an inescapable similarity to syphilis, end quote. The particular table was presented at a 2001 conference on Lyme disease and is also included in the textbook. In 2005, a pediatrician specializing in Lyme identified symptom presentations of 102 pediatric patients obtained through case reviews, whom he had diagnosed with gestational Lyme in his clinical practice. Of these, he identified cardiac abnormalities, neurological manifestations, orthopedic disorders, GI symptoms, cognitive and speech delay, and neuropsychiatric symptoms. As you can see from this list, symptoms are heterogeneous and wide-ranging. He noted that the diagnosis can be complicated due to a delay of presentation. Symptoms can vary in degree of severity and change as the disease progresses. He also notes the unreliability of standard diagnostic tests. He identifies that symptoms may present subtly at birth. Most children were diagnosed between 1 and 5 years of age. Identifying the full consequences of prenatal exposure to Lyme can and must be better studied. Gardner highlights the necessity of large-scale longitudinal prospective studies of sufficient numbers of patients with gestational Lyme borreliosis, including follow-up to determine pregnancy outcome of each enrolled patient, Borrelia burgdorferi specific evaluation of any fetal or neonatal demise, and long-term follow-up of each infant born to determine the occurrence of possible early and late sequelae. Dr. Lambert, an infectious disease clinician and researcher from Ireland, also iterates the necessity of prospective studies. And furthermore, he states, and I quote, "The literature on congenital Lyme is at present incomplete due to lack of intensive investigations, lack of longitudinal follow-up of exposed infants, as has been done for another spirochete syphilis." There's no doubt that congenital infection occurs with Borrelia. Whether a congenital syndrome occurs as a result of this in utero infection remains to be further investigated, end quote. With congenital Lyme, there is no specific pattern of teratogenicity, similar, for example, to Hutchinson's triad in syphilis. But it is important to note that identification of a congenital syndrome isn't a prerequisite to addressing congenital transmission. It's also important to note that even in syphilis, despite the identification of a specific syndrome, the majority of babies infected are asymptomatic at birth without signs or symptoms. In the case of congenital Chagas disease, a parasitic vector-borne infection which can be transmitted in utero, neonatal infection doesn't present with defining clinical signs and features as identified by the CDC on this slide. In fact, newborns are often asymptomatic or have subtle manifestations. So as more vigorous investigation is initiated into gestational Lyme, perhaps over time, a specific pattern or phenotype of common signs or symptoms will emerge. The timeline of North American research and publications on Lyme disease in pregnancy and congenital Lyme ranges from 1985 to present day. There have also been several publications from Europe and Russia which are not represented on this specific timeline. From 1999 onwards, which is over 20 years, there has been no large-scale, multi-center, government-funded research exploring this alternate mode of transmission, despite many past investigators clearly highlighting the necessity of large-scale prospective studies as a next step. In the fall of 2020, the McMaster Midwifery Research Centre in Ontario, Canada, launched new research on Lyme in pregnancy and continues to recruit participants. Detailed information on this study, which is open to participants internationally, can be found on our Lyme Hope website under the Research tab or through the direct link posted on the slide. Any person with pregnancy, irrespective of Lyme disease, can participate, so please do share this opportunity within your research circles. So what is the best diagnostic approach to detect Borrelia burgdorferi infection in a pregnant mother and neonate? I'd like to start with this slide and a quote by Dr. Dennis in a 1991 paper in JAMA titled Lyme Disease, Tracking an Epidemic. And I quote, "Like syphilis, Lyme disease has been called a great imitator and is often difficult to diagnose clinically, particularly when erythema migrans is absent," end quote. So how are pregnant women identified with Lyme if they lack the typical history or tick bite followed by an erythema migrans or other objective clinical symptoms? There is some research which gives us clues that symptoms of Lyme may be attenuated in pregnancy. Marker 1 on this slide highlights a 2001 study in pregnant mice, whereby the severity of arthritis was significantly reduced compared to non-pregnant mice who were also infected with Borrelia burgdorferi. Marker 2 highlights similar findings in a 2006 study, this time investigating Borrelia dutonoi, which is a relapsing fever Borrelia. Investigators reported a significant reduction in symptom severity in pregnant mice, and they also identify that the attenuation of symptoms in pregnant mice did not prevent the offspring from being infected. In fact, they found a 74% rate of transplacental transmission. Marker 3 highlights findings from a 2020 study by authors from Slovenia, which Holly mentioned earlier, whereby they identified that the clinical course of early Lyme during pregnancy was either milder in pregnant versus non-pregnant women. Given the known pathophysiologic changes and hormonal shifts during pregnancy and resultant modulation of the immune system, could this also impact the maternal immune response to Borrelia burgdorferi and thus sensitivity of current diagnostics? Development of novel diagnostics must be inclusive of this special population for both pregnant mother and infant, and highlights the importance of the formation of a Lyme in pregnancy registry and sample biorepository, which researchers can access to carry out specific research. Dr. Alan McDonald, a pathologist from Southampton Hospital in New York, authored a comprehensive review of 14 cases of adverse fetal and neonatal outcomes of gestational borreliosis. He raised concerns about the reliability of serology to identify infection in pregnant women and states, and I quote, "The tendency towards seronegativity in pregnancy makes maternal serology a less satisfactory discriminator of maternal infection and useless as a practical tool to predict the actual state of the fetus." Several of the cases which he reported on, whereby Borrelia burgdorferi was identified upon fetal autopsy, the mothers had no history of tick bite or erythema migrans, which raises the concern of subclinical infection. He also raised similarities to prenatal syphilis and states, "It is my expectation that the spectrum of gestational Lyme borreliosis will expand into many of the clinical domains of prenatal syphilis." In this NIH-funded study published in 1996, investigators studied placentas of asymptomatic women with a reactive ELISA. 5%, or 3 of 60 placentas, were positive for spirochetes by silver staining, and 2 of 3 of these were PCR positive for Borrelia burgdorferi. The 3 women who had spirochetes in their placentas had equivocal ELISAs, and 2 of 3 were negative by Western blot. So, by the current CDC case definition, 2 out of 3 of these women would be considered not to have Lyme disease, and the third would be considered borderline. The authors suggested that the presence of these spirochetes implies fetal transmission. The 3 mothers did not have a known history of tick bite or symptoms of Lyme, and cord blood testing of their babies was negative by IgG and IgM Western blots. Would these moms be considered to have a subclinical infection? Could they silently be transmitting Borrelia burgdorferi spirochetes to their baby? The study confirms the unreliability of standard diagnostic tests in pregnancy to detect Borrelia burgdorferi infection. And this is exactly what Dr. McDonald had reported years earlier, a disconnect between serology and pathology. Authors recommended that long-term follow-up of infants born to mothers with placental spirochetes was needed to determine what effect, if any, placental spirochetes may have on the growth and development and health of these individuals. This hasn't been done and must be prioritized. So what is the best way to diagnose congenital Lyme infection in a neonate? There are several clues in the literature regarding possible diagnostic approaches. This little case report on neonatal Lyme identified a case of a baby born with neurologic dysfunction whose mother had been treated for Lyme in her 2nd trimester. Borrelia burgdorferi specific antibody was identified in the infant's cerebrospinal fluid, and they noted that the mother did not have diagnostic antibodies at the time of birth. Several complexities of gestational Lyme compressed into a short paragraph. And in this same report, authors identified that Borrelia burgdorferi specific responses were detected by both humoral and cellular testing methods of previously infected neonates. Utilizing cellular Borrelia burgdorferi specific responses was also identified by Dr. Gardner in her chapter on Lyme, whereby in 4 cases of congenital Lyme, documented from her practice in the chapter, in all cases, the infants were seronegative by standard ELISA, but the diagnosis was subsequently confirmed by a test detecting cellular Borrelia burgdorferi specific responses. Several studies in the US, which were performed in the 80s and early 90s, relied on cord blood IgM as a standalone endpoint to identify congenital infection, as IgM does not cross the placenta and thus would originate from an infected infant. In all cases of samples tested, a positive IgM was never reported, and this may have brought a measure of relief to investigators, but it needs to be asked, is cord blood IgM really an adequate measure to rule out infection in a neonate? None of these studies identified the possible limitations of testing cord blood IgM. If one looks to research done in other congenital infections, investigators recommend against IgM as a stand-alone measure to rule out infection, given issues with sensitivity. If IgM is positive, that indeed is an indicator of current infection, but if negative, this result cannot be used to rule out infection. For example, when it comes to congenital toxoplasmosis, IgM or IgA tests could fail to identify approximately 20 to 50% of cases, and in cytomegalovirus, IgM sensitivity ranges from 20 to 75%. For syphilis, the CDC clearly recommends against commercially available IgM testing and also states that even a negative, quantitative, non-treponemal serologic titer in the infant does not exclude congenital syphilis. If we look to other congenital infections and how they are diagnosed, diagnostic criteria cast a wide net beyond IgM and include microscopic detection, culture, PCR, nucleic acid testing, and others. So what is the appropriate testing methodology to identify congenital Borrelia burgdorferi infection? Could a congenitally infected neonate express an altered immune response to an infection that they were exposed to in the womb, and thus have a different serological phenotype or profile compared to those who've been bitten by a tick. In other congenital infections, it has been identified that infection during the first 20 weeks may result in the lack of fetus to develop an immune response to a foreign pathogen as their immune system is immature. Could the same thing be happening with Lyme? If we go back to the textbook chapter on Lyme by Gardner, she identifies diagnostic testing for the evaluation of congenital Lyme, which includes direct and indirect testing methodologies, as well as multi-specialty assessment and follow-up, full histopathologic testing, and more. So how can these recommendations be actioned and used in clinical practice? The answer is the development of interim guidelines for the evaluation, treatment, and follow-up of infants born to mothers with Lyme during pregnancy. These could systematically guide and assist frontline clinicians caring for pregnant patients with Lyme and with babies who may have been exposed to Lyme in utero. The guidelines could identify appropriate laboratory tests, assessment tools, treatment recommendations, and recommendations for histological evaluation. It could be modified as more data accumulates, but would serve as a necessary starting point. And similar guidelines have been initiated and were initiated for West Nile virus. When it was first determined in 2002, the guidelines were created in 2003 for West Nile virus and women who had infected their babies with West Nile virus and how to identify that cohort. What is the best treatment approach for Lyme in pregnancy and for babies exposed in utero? Very quickly, there's agreement between the three slides listed on this, the three studies listed on this slide, that treatment results in good outcomes. And a 2018 meta-analysis of 9 studies, which I've bordered in red, also identifies that untreated pregnancies result in a 50% rate of adverse outcomes as compared to 11% in treated cases. So what is the best treatment protocol for gestational Lyme? A 2007 report from authors in the Czech Republic identified detection of Borrelia burgdorferi by PCR in cord blood of 2 cases of infants born to mothers who were treated for Lyme. A second paper published in 2011, also from Czech authors, identified 12 cases identified between 2008 and 2010, where Borrelia burgdorferi was identified in placentas by PCR and electron microscopy of mothers who've been treated in their first trimester. A group of researchers from Stony Brook authored a paper published in Clinical Infectious Disease from 1989 titled A Perspective of Treatment of Lyme Borreliosis. They identify, and I quote, "The aim of treatment of early Lyme disease during pregnancy is not only to treat the infection and prevent long-term sequelae, but to eliminate the infection as quickly as possible, so as to prevent congenital transmission to the fetus." The orange box on the bottom highlights, and I quote, "that no study has established optimal treatment, and further studies must establish the duration of therapy necessary to eradicate this infection and thus prevent congenital transmission. 30 years later, this issue remains uninvestigated and must be taken seriously." I want to highlight this quote from Williams and Strabino, who were co-investigators in early epidemiological studies on Lyme in pregnancy. And they state this: "The prevention, diagnosis, and treatment of Lyme disease is a formidable new challenge in medicine today. In no specialty is there greater concern for the adverse effects of this disease as in obstetrics, where the full consequences of prenatal exposure are as yet unknown." So I'm going to close off with a short story, which is a true story, a case of a child and family impacted by congenital Lyme. The journey to access diagnosis and treatment was a struggle. I have permission to share this story. The girl's mother had a challenging pregnancy, was sick with fever and flu-like symptoms in her first trimester, but no diagnosis was given, and she had no recall of a tick bite or erythema migrans rash. The girl was born at 37 weeks, and from birth was fussy and inconsolable. At 2 days of age, was hospitalized with jaundice. Around 11 weeks, she developed a high fever. However, no other common cause of infection was identified, and she was treated with a dose of ceftriaxone. Over time, her symptoms progressed with regular fevers, cyclical vomiting syndrome, complaints of abdominal pain and leg pain. She became sensitive to light, touch, and sound, and had balance issues. She had dark circles under her eyes and was not gaining weight. All diagnostic evaluations were unrevealing, and it was a medical detective type situation. At the age of 4, this girl's mother was diagnosed with Lyme after over a decade of trying to seek answers for complex health issues. She was positive using CDC criteria, but she had never recalled a tick bite. And so Lyme and tick-borne disease was never considered in all the years prior of her clinical investigations. Following the mother's diagnosis, the child was tested. She was negative by the standard ELISA and considered not to have a Lyme infection. But a separate IgG Western blot revealed highly specific Borrelia burgdorferi antigens, including OspA and B, just bands 31 and 34. Her IgG Lyme Western blot was negative by CDC criteria, as OspA and B are left out of interpretation, even if positive. A third test measuring a cellular response to Lyme was also positive. And despite positive laboratory findings and progressive, complex, multi-system manifestations, this mother felt like she had nowhere to turn. She was advised there was no scientific evidence that Lyme could be transmitted in utero, and that if her child had Lyme, she'd be undoubtedly positive using the 2-tier criteria. The mother's concerns were dismissed or met, silence and apathy. When the child was 5, she developed another severe fever, followed by a constellation of rashes. You can see rashes on her legs, which were, the mother would be told later to be secondary transient migratory erythema migrans rashes. They had the appearance of central clearing, but it was the dead of winter and there were no ticks. The cyclical vomiting continued. The child started crawling because her knees and legs were in so much pain. She had involuntary muscle twitching, but still, with all these symptoms, her ELISA was negative. The parents were able to obtain medical care from a physician specializing in Lyme, and the child was diagnosed with congenital Lyme and Bartonella. She was treated with oral antibiotics, which resulted in miraculous improvement. The cyclical vomiting resolved, as did the pain in her legs and joints. The fever stopped, and so did the sensitivity to light, touch, and noise. She started gymnastics and was able to walk a balance beam. She gained weight. The dark circles under her eyes disappeared. She started to thrive. I share this case because as healthcare professionals, clinical researchers, and scientists, we have a precious gift that we can offer this little girl and her family, and indeed families and children like her across the globe, each with a unique story and journey, many heartbreaking, many who feel their voices and concerns have either been silenced or ignored. The gift we can share with those impacted is our expertise and utilization of state-of-the-art science to further investigate the complexities which I've shared today. Science can and will lead the way. Exploring each puzzle piece over time, a more complete picture will evolve. So in conclusion, I'm just going to quickly review the research opportunities which I've identified in tonight's talk. Development of interim guidelines for assessing, testing, and treating infants born to mothers with Lyme disease, multi-center long-term prospective studies, novel diagnostic methods to detect Borrelia infected mothers and babies, Lyme and pregnancy registries and biorepositories, effective ways to screen pregnant women, research into maternal and neonate immune response, breast milk studies, research into optimal treatment for maternal Lyme and congenital Lyme, experimental animal models, which could explore pathophysiology of disease, possible biomarkers of congenital infection, investigation of effects of chronic versus acute infection in pregnancy, and of course, other prevention strategies. In closing, I want to acknowledge my husband and children, and indeed all the families and children who suffer and struggle with Lyme and tick-borne disease. I also want to acknowledge Joanna, Christine, and Michael Morrow for their valuable research and support, and researchers, clinicians, scientists, and government officials here and on this call, willing to listen, extend a hand, and engage. Thank you so much.
And thank you so much, Sue, for that thorough overview. Now I'd like to turn the program over to Dr. Nihita Shaktura, Maternal and Pediatric Infectious Diseases Program Officer at the National Institute of Child. Sorry, my notes just disappeared.
That's okay. I can introduce myself. No problem.
Thank you, Dr. Shaktura.
Thank you for the invitation, for inviting us to share information on research opportunities at NIH. My name is Nihita Shaktura. I'm a medical officer in the Maternal Pediatric Infectious Disease Branch at the Eunice Kennedy Shriver National Institute of Child Health and Human Development. Next slide, please. I will start. Next slide.
1 second, I'm trying.
Okay, no problem. So I'll start talking a bit about NICHD, followed by the NIH application and review process. You want to keep going? I'll go ahead and keep going while you catch up. So NICHD's vision is for healthy pregnancy, healthy children, and healthy and optimal lives. Our strategic plan focuses the Institute's research and training efforts to understand human development, improve reproductive health, enhance the lives of children and adolescents, and optimize abilities for all. The Institute's research goals and objectives fall under 5 broad research themes. One is understanding the molecular, cellular, and structural basis for development. Number 2 is promoting gynecologic, andrologic, and reproductive health. 3 is setting the foundation for healthy pregnancies and lifelong wellness. 4 is improving child and adolescent health and the transition to adulthood. 5 is advancing safe and effective therapeutics and devices for pregnant and lactating women, children, and people with disabilities. Infectious agents are sort of the weave throughout these themes and continue to pose significant threat to maternal health and child development. So at the same time, pathogens with previously unknown disease-causing properties constantly evolve and emerge, such as COVID recently. So NICHD plans to improve the basic understanding of how infectious pathogens affect pregnant women and young children and address the impact of infections on reproductive and overall health in children and adolescents and advance safe and effective treatments for pregnant and lactating women, children, and people with disabilities. So as such, NICHD led the PREGLAG activities. The PREGLAG is a task force on research specific to pregnant women and lactating women to advise the Secretary of Health and Human Services regarding gaps in knowledge and research on safe and effective therapies for pregnant women and lactating women. PREGLAG was tasked with identifying these gaps and reporting these findings to the Secretary. The task force included federal members, NICHD, NIH, CDC, HHS Office of Women's Health, and the Commissioner for Food and Drugs. Non-federal members included representatives from relevant medical societies, nonprofit organizations, and industry. Next slide, please. The bulk of, so just to start with the NIH application and the review process, the bulk of NIH support goes to investigator-initiated efforts. So investigators can submit research applications to parent announcements or notices. Most applications submitted are based on various mechanisms that differ in terms of years and amount of funding. They also differ in the amount of preliminary data and have different requirements. So next. So talk a little bit about the review process. So applications compliant with NIH policy and assigned to an NIH are assigned to an NIH institute or center and to a scientific review group for the evaluation of scientific and technical merits. The applications go under sort of a rigorous 2-stage or dual arm of scientific peer review. The first level is carried out primarily by the non-federal scientists, while the second review, second level review, is done at the level of the Institute Advisory Councils and approve the results of the initial peer review meetings. The meetings are open to the public except when confidential or proprietary information is involved. The advisory council members are noted on the websites for all the institutions, including NICHD. Next slide. So though the bulk of the NIH-supported activities go to investigator-initiated efforts, there are currently 2 funding announcements or opportunities that are available, and they're listed there. Next slide. Applicants are encouraged to reach out to program officers like myself to discuss their scientific ideas, and you see my email there. And I think it's important to note that there's sort of a separation between the review process and program officers, which allows us to interact with the scientific community without causing any conflicts of interest. And so which is why we can speak with the investigators. And I think the other component that I think is helpful is that for individuals that are new to NIH and the NIH process, the NIH Office of Extramural Research sponsors regional seminars on program funding and grants administration. These seminars are intended to help explain the application and review process, clarify the federal regulations and policies, and highlight the current areas of special interest or concern. These seminars serve the NIH mission of providing education and training for the next generation of biomedical and behavioral scientists. Thank you very much for the opportunity to share this, and I will pass back the mic to Isabel.
Thank you very much. So finally, we will hear from Dr. Maliha Ilyas, Lyme Disease Program Officer at the National Institute of Allergy and Infectious Diseases. Dr. Ilyas.
Is everybody able to hear me okay?
Yeah.
Okay, awesome. Thank you. So good evening, everyone. My name is Maliha Ilyas. I'm the Prime Program Officer for Lyme Disease Research at the National Institute of Allergy and Infectious Diseases. I manage the portfolio of research grants and contracts that are focused on all aspects of Lyme disease and are funded by NIH. I want to thank the organizers of today's webinar for inviting me to talk about the recent NIH notices and announcements related to Lyme and tick-borne diseases. We always appreciate the opportunity to clarify the NIH grant application and review process. Next slide, Noah. So NIAID is committed to research on all aspects of Lyme disease across the lifespan. So as such, my presentation today applies to anyone interested in research on any aspect of Lyme disease and tick-borne diseases. We are aware of and committed to the importance of research on special populations. As my colleague Nahida mentioned, our clinical research studies are required to consider including women, children, and diverse racial groups. Not including any of these groups in clinical research studies needs to be appropriately justified by the investigator, and that justification needs to be appropriately assessed by reviewers. I'll also mention the HHS Tick-Borne Disease Working Group, in which federal agencies such as NIH and CDC are also represented. This particular working group has highlighted the need for more research on special populations, especially children and pregnant women, in its 2018 report to Congress. I know that another speaker today also mentioned that. So NIAID is continuing and strengthening our efforts to highlight research on special populations, such as children and pregnant women. I'll be discussing some of these efforts in the following slides. Next slide, Noah. Thank you. So the first report of the working group was presented to Congress in 2018 and included specific recommendations. In keeping with one of these recommendations, NIH published its first tick-borne disease strategic plan in 2019 with input from all institutes involved in tick-borne disease research, along with public input elicited through an RFI, which stands for Request for Information. The strategic plan is published online. You can Google it, and it highlights various aspects of Lyme and tick-borne disease research, including diagnostics and treatment. It also stresses the need for more research to focus on special populations, such as children. A notice of special interest was published in 2019, linked to the strategic plan, but I will talk about that a little bit later. Next slide. In addition, the National Institute of Allergy and Infectious Diseases has web pages dedicated to Lyme disease research, which we try to continually update. Specifically, since 2015, NIAID has been updating a publicly available report on current efforts in Lyme disease research that attempts to provide research highlights on the Lyme projects that NIH Extramural is funding or NIH Intramural is engaged in. Again, we update this report periodically, and we will be making a special effort in the next update to highlight research on special populations. I also wanted to mention that for anyone interested in exploring the grants that have been funded by NIH on any topic, not just Lyme and tick-borne diseases, the NIH Reporter is a great resource. It allows you to search for grants on various topics and is especially useful for investigators looking for opportunities to collaborate with other researchers. Next slide, please. So I wanted to mention some notices and announcements that may be of interest to anyone looking to apply for funding for Lyme and tick-borne disease research through NIAID, through NIH. I mentioned that the NIH strategic plan for tick-borne diseases resulted in a notice of special interest that seeks to advance research on tick-borne diseases. It encourages new applications to advance research activities relevant to the 5 strategic priorities identified in the strategic plan, namely to improve fundamental knowledge of Lyme and tick-borne diseases, to advance research to improve the diagnoses of Lyme and tick-borne diseases, accelerate research to improve prevention, promote research to improve treatment, and to support tools and resources to advance research in understanding, preventing, diagnosing, and treating Lyme and tick-borne diseases. I wanted to mention second on my list, a trans NIH notice of special interest, which was published very recently to invite SBIR, STTR applications. For folks who may not be familiar with that mechanism, SBIR, STTR are small business research applications, small business innovation research applications, and small tech transfer research applications. This particular notice focuses on this mechanism and invites applications to develop technologies or tools to quantitatively predict or indicate an increased risk for maternal morbidity and mortality. This notice is part of the IMPROVE initiative, which stands for Implementing a Maternal Health and Pregnancy Outcomes Vision for Everyone, which supports research to reduce preventable causes of maternal deaths and improve health for women before, during, and after delivery. Various institutes are actually participating in this notice, and NIAID has specifically highlighted the need to develop and validate diagnostics for gestational Lyme disease, which can adversely impact maternal health and pregnancy outcome. I wanted to mention a NIAID program announcement to understand the contribution of specific elements of maternal molecular and cellular factors that can control and affect the development of the fetal immune system. The notice, I wanted to mention that there's a notice number that I've attached to each of these. You can use that number to Google these notices and all the details will pop up, including how to apply and the specific points of contact for each of these announcements. Last on my list, I want to mention 2 targeted funding opportunity announcements that look to support research to define the mechanisms regulating the establishment, development, and maintenance of immunity throughout childhood, that is from birth to less than 18 years of age. This program will establish collaborations, hopefully, among immunologists, neonatologists, pediatricians, systems biologists, and microbiologists to expand our knowledge of the developing immune system, fetal immune system. Knowledge obtained through this program, we hope, is going to be applied to design improved vaccines and immunotherapies to combat infections or prevent or treat immune-mediated diseases in this vulnerable population. I wanted to mention, again, you can see 2 notice numbers here. It's the same notice. They only differ based on which one allows clinical trials and which one does not. Next slide, please. So as I mentioned earlier, the announcements include details on how to apply and also have dedicated points of contact noted. But depending on your area of research, you can reach out to the appropriate program officer. For example, I would be the appropriate program officer for any research related to Lyme disease. My colleague Nahida Shaktura would be an appropriate program officer for grants related to maternal and perinatal infectious diseases. I know that the NIH grant application process is a bit daunting and may seem complex to folks who are applying for the first time. So I wanted to include 2 links that may come in handy. One provides an overview of the NIH grant process and includes helpful tips and videos and everything from grant writing to walking you through the review and approval process. And I've also included a link on sample grant applications. This one has samples for applications to many of the common mechanisms, such as R21s, which are exploratory research grants, as well as R01s, which are for larger research projects which require more time and money. Again, program officers are a great resource for investigators as you navigate this process, and especially as you try to determine which mechanism or which notice you should apply to. I want to repeat again that my presentation today pertains to anyone interested in applying for research funding on Lyme, on any aspect of Lyme and tick-borne diseases through NIH. My colleague Nahida has already walked us through the NIH grant application and peer review process. I want to reiterate that most NIH-funded grants are investigator-initiated, and the only applications that can be funded are the ones that are submitted. So feel free to contact your program officers. That's it for me. Passing it back on to you guys.
Terrific. Thank you so much. In fact, you answered the first question that I was going to ask you. And so I'm which was going to be if there were any tips on writing these grant applications, because I do know how daunting they are. Holly, is there anything that you as an academic want to add to Dr. Elias's words, that a grant writer could turn to for support?
Thanks, Isabel. The need for research, there was a lot of research that had been left on the table that serves as a great starting point for moving forward now. And so, a historical review of the literature is a great place to start. And, the need for research is great. And it's wonderful that NIH is there to support that. And, I'm hope that Congress will also support that through appropriations for funding for these research projects, because that's where it all comes from. So, it's a great step forward and, something that we can build on.
So where do we need to begin? What are the most pressing areas of research?
Well, I'm going to assert that the most pressing area for research is a clinically accurate diagnostic test for Lyme disease that will be able to discriminate between who has it, who doesn't, who's recovered from it, which is something that we do not have now. So that is for all populations, not just, pregnant moms or other special populations, for all populations. And once we have that test in place, then we can measure the true extent of this disease and, look at other approaches going forward. But that, I think, should be a priority. I believe it is a priority. It's something that the NIH has put into their strategic plan, is something that both working groups have made recommendations on. And I know that HHS it's a priority moving forward with HHS as well. So,
Sue, what do you have to say about that? What other than this diagnostic do you think is pressing?
I really think the Lyme and pregnancy registry being reinitiated is critical, because until we understand the numbers of women who are impacted in their pregnancy and start collecting that data. So I think that's I can't say it's an easy thing to do, but I think it's a necessary thing to do. And then the second piece, again, that I had shared in my presentation was just interim guidelines. And interim guidelines don't have to be the authoritative final product. They are a starting point. Because right now there really is there's no guidance on how to even identify a baby who might be infected. Apart from, I think the only guidance I've ever seen is looking for cord blood IgM, which I've already identified, might have some sensitivity limitations. So I think, getting guidance together, bringing experts who have expertise historically, bringing them forward to help initiate something like this would be critically important.
Great. Dr. Shaktura, I have a question that's come in for you.
Okay.
Comes from Dr. Jane Mark, MD. Given the interest that NICHD has in the growth and development of children from fetal development through adulthood, would NICHD be willing to support longitudinal studies of such children? Would NICHD be willing to participate in recruitment for such studies, as expecting a bottoms-up approach might be difficult?
Thank you so much for that question. Just to reiterate what Malia said, so most of the research that we support is investigator initiated. And if individuals submit applications that get reviewed and favorably reviewed, we would be able to fund. And just from the perspective of NIH helping recruit, generally NIH does not, we fund extramural researchers, but we don't necessarily participate in the research with the extramural researchers.
Okay. Here is a question from Dr. Alan McDonald. Is there a tissue registry or tissue bank which represents proven cases of gestational Lyme borreliosis? If such a tissue bank exists, what is the application procedure for researchers to request infected tissue samples for research study? Dr. Elias, do you have any knowledge of this?
Sure, Isabel, can you hear me?
Yeah.
Okay. Yeah, no, so I don't actually know of any tissue registry or tissue bank, but what I can generally answer about repositories in general, there's the CDC NIH repository. They have samples for Lyme disease, and a lot of researchers actually access them. They don't have the type of samples that this particular individual is asking for, but just to sort of answer his question about how to ask for samples, you know, CDC NIH repository, you can reach out to them and they can inform you. I know that the Bay Area Lyme Biobank also has samples. Again, I do not think they have these type of samples, but if you want any of their samples from Lyme patients, you can reach out to them directly and they should be able to guide you.
Great. Here is another question from our panel, from the House today. What work has been funded by NIH on maternal fetal transmission of TBD? If they haven't been funded, why not?
Do you want to take that,
So
Maria?
this is, yeah, thank you. Okay, so yeah, you know, this is interesting because Nahida and I actually don't see much research on this topic coming into our portfolios. And we don't mean funded research, we mean submitted applications. So if it was the issue that we were seeing a lot of applications come in and not getting funded, that's a separate issue, but we're really not seeing any applications being put in. So it's very hard for us to tell where the gaps are. We really need the research community to sort of point us in that direction. And I want to piggyback on something that Nahida said earlier, which is that the bulk of NIH research is investigator-initiated applications. And that is done with a purpose because we don't want to dictate the direction the science takes. We want the scientists and researchers in the field to dictate those directions, to identify the gaps and then to put in applications accordingly. So yeah, that, I mean, we don't have a lot of applications being submitted right now.
Okay, well, for our researchers out there, get busy. Here's another question from the House, the audience. How do experts and advocates apply to serve as public representatives on the grant review panels at NIH?
Nahida, do you want me to take a stab at it, then I'll hand it over to you?
Sure, absolutely.
Okay. Yeah, so for peer review, again, I think Nahida mentioned that the Center for Scientific Review is a great website for a lot of information. They actually have information on how to become a reviewer. What I will point out is that our peer panels are made up of scientific and technical peers. So these are people with the scientific and technical expertise to actually assess applications in terms of their approach and their innovation and other aspects. Even program officers do not review applications. So that is, I think, one of the key criteria when folks are asking to apply to these study sections, but that information is available on the Center for Scientific Review website. If anybody is interested, they can go take a look at that.
Somebody is asking, I have been unable to locate any type of gestational Lyme samples in the past 2 years. Would the NIH support collection of samples? Is this not in your jurisdiction?
Yeah, it's not. I mean, this would, again, Nahida kind of pointed to that we can't really dictate that research. It has to come from the researchers themselves.
I'm looking at the time and I'm thinking that sadly we need to wrap up, correct, Noah? So what I want to do is tell you that if you submitted a question, we will do our very best to get back to you outside of the time limits of this particular webinar. And I want to thank you so much, Professor Ahern and Sue Faber, Dr. Ilias and Dr. Shutura. And thank you to all attendees. Bruce Fries, the mastermind behind tonight's webinar, deserves a special thanks, as does Noah Johnston and Project Lyme for their true partnership. I want to remind everyone that the NIH has issued a notice of special interest and encourages research on gestational Lyme disease and the effect of pregnancy on immune response. And I also want to encourage you all to contact the NIH program managers directly for further guidance should you need it. Dr. Ilias has said that to us many times. Is that correct? That people can reach out?
Investigators reach out to us all the time to talk about their research, yes.
please spread the word to your colleagues about research funding opportunities in this area, and look out for future opportunities to learn more through our upcoming webinars and CME courses. We will be posting all of this information on the website Mothers Against Lyme, which is mothersagainstlyme.org, and also Project Lyme. Is that .org, Noah, or .com? .org, projectlyme.org. And I want to thank you all and wish you a good night.